Welcome everyone, this is Eda and I'm with Turkish trainees of OBGYN. We would like to thank Associated Professor İlker Selçuk and ENTOG for organizing this webinar. I will now hand over to my colleague, Mert.
Thank you. I'm sharing my screen. Can you see it now?
Yes, we can see it now.
Thank you for your collaboration and thank you, Associated Professor İlker Selçuk, for this opportunity. I'm ENTOG Executive Committee member and I'm going to make a short presentation about ENTOG. ENTOG is the European Network of Trainees in Obstetrics and Gynecology. It's a non-profit organization that unites and represents all the trainees across Europe. We have 36 member countries. And our executive committee for 2025 and 2026 is here. Sofia is our president. Rafal is our secretary. Sara Vodopivec is our treasurer. Mei Neg is our webmaster. And I'm an executive member from Turkey. We have many partner societies and we are an official organization and we are operates under the EPCOG and we have a strong collaboration with WATOG. Other than this, we have European subspecialty societies that are partners like EUROPAC, ESGE, EUGA, European Association of Perinatal Medicine, EMAS, and we have international collaborations with ISSVD, ISHOG, and IPVS. What we have done so far in 2025, ENTOG Exchange was held in Germany in 2025. We had 48 trainees from 25 ENTOG member countries, and we had our scientific night and social event on 4th of June in Mainz. After exchange, we had our EPCOG Congress in Frankfurt, and ENTOG was very active during the Congress, and we had 21 co-chaired sessions, 7 oral presentations, 2 full ENTOG scientific sessions, workshops, and ENTOG prize for the best abstract. We had webinars in 2025. We had a webinar with ISSVD, and we had a webinar in early 2026, researching female sexual dysfunction, tools, techniques, and translational practice. And our next exchange is in Ireland, 2026. It's going to be held in Dublin. So you can follow our website and register to the exchange program. And we are upcoming webinar is with EMAS. It's going to be held in March 18 and 19. It's a 2-day webinar, so you can register via EMAS or ENTOG website. And we have active 2 surveys. First is animal model usage in OBGYN training, and the second one is training in chronic pelvic pain. You can answer and join our surveys via the website. And our upcoming partner society congresses are EuroPAC 2027, ABC of Sexual Medicine. Heartes is going to be in Rome in April, and we have MISAC Academy in April in Portugal. And our upcoming exam, actually we have fellowship exams and you can register through EPCOG or ENTOG website. In 2026, first exam will be held in 14th of March, and the second one is going to be on 29th of August. And we have also European Diploma in Sexual and Reproductive Healthcare. You can also find more information in our website. And our exchange for 2027 and our Congress, EPCOG Congress, is going to be in Rome. So you can say that it's going to be in May. So thank you very much, and please follow up us to keep updated. We have a very active Instagram account and Facebook accounts. You can also follow EPCOG through the Instagram. And I'm going to present Associated Professor İlker Selçuk, and thank you to support us. He is an MD, PhD, and an associated professor currently serving in Ankara City Hospital, Bilkent City Hospital, in Department of Gynecologic Oncology. He is a certified gynecological oncologist who completed subspecialty training in Zeki Aytay Burak's Women's Health and Education Research Hospital. He also holds a PhD in anatomy and completed his PhD in Hacettepe University. In addition to extensive clinical and academic experience, he served as a member of executive group of European Network of Young Gynecologic Oncologists from 2017 to 2021, and as the ENYGO National Representative of Turkey between 2015 and 2017. Also, he has a YouTube channel that you can follow and watch his videos. Thank you.
Dear colleagues, thank you very much for this brief introduction. I'm very honored and it's a pleasure for me. I know very well my colleagues Eda and Mert. They are very hardworking and they are enthusiastic in obstetrics and gynecology. They follow a good path in this program and also in this education environment. So I believe that their future will be very bright. And today it's my honor again, I would like to say that, to present this lecture as an invited lecturer by ENTOG. I viewed the activities of ENTOG via this presentation, and I want to congratulate ENTOG for this kind of activities and bringing together all the residents and young specialists in this good structure. And keep going, guys, keep going. So my presentation will start by some figures. We will briefly understand the surgical anatomy of the pelvis. Let me share my screen. Today I will share many unpublished documents which are ahead of publication. And just give me a second. Which are ahead of publication. And you can also find many of them from my ResearchGate and profile, also from the PubMed. You may find them. Now I'm sharing my screen. Please correct me if can.
We can see, yes.
Can you see full screen?
Yes, we can see.
Full screen, okay.
Full screen,
Now,
yes.
okay, very good. Now, guys, let's start with the pelvis. And this is the pelvic point of view from an open surgery. And you can see that all the abdominal pelvic cavity is covered by the peritoneum here. Just a second. I'm going to stop the share and open this presentation from another document. Just a second. That will be much more better. Just a few seconds. Okay. Now I'm going. I think you can see the full screen. Yes, I'm sure. Okay. Guys, this is the pelvic cavity. All the abdominal pelvic cavity is covered by the peritoneum. You can see that this is the peritoneum. This is the pelvic point of view from an open surgery. This is the uterus at the middle of the pelvic cavity. Anteriorly, the bladder, and posteriorly the rectosigmoid colon. At the lateral side, the lateral pelvic peritoneum, and when we cut it, we can notice the psoas major muscle at the lateral side of the pelvis. This is a major landmark for pelvic orientation. But from this figure, you must understand that all the abdomen pelvic cavity is covered by the peritoneum, and the abdominal pelvic surgery is based on deperitonization. You can mobilize the parietal peritoneum, which is covering the muscles or fascia in the abdominal pelvic cavity, or the visceral peritoneum, which is close to the visceral structures like omentum or the bladder or rectosigmoid or the stomach, like that. And so, as a consequence, the abdominal pelvic surgery is deperitonization. Okay. Here, when we cut the peritoneum at the lateral side, we can notice the psoas major muscle and external iliac artery and vein attached to the psoas major muscle at the medial side. So the second slide, we can go with the retroperitoneal areas. To understand the retroperitoneal areas in the pelvis, we must be familiar to the anatomy of the para-aortic region. This is the para-aortic anatomy. Here you can see the major vessels, great vessels at that area. When we cut the peritoneum between the radix mesentery of the small intestines and the descending colon, rectosigmoid colon, when we dissect the retroperitoneal fatty tissue at the para-aortic area, this is the right side paracaval area, paracaval space, and this is the left side lateral aortic space. You can notice that. And this is lateral to the aorta, and this is lateral to the inferior vena cava. So here, the anatomical landmarks are aortic bifurcation at the L4, L5 vertebral level, inferior mesenteric artery at the L3 vertebral level, and left renal vein, which is passing anterior to the aorta at the L1 vertebral level, end part of the L1 vertebral level. So here you can see that the right and left common iliac arteries and right and left common iliac veins. The left common iliac vein lies between the both common iliac arteries, and the right common iliac vein lies lateral and posterior to the right common iliac artery. Here, left common iliac vein is very important. It's at the anterior portion of the promontory, and so it is at the same level with the umbilicus. And during varus entry during laparoscopy for the optic trocar insertion, before the optic trocar insertion, you may injure this left common iliac vein for the very thin patients. Be careful for this, for the very thin patients. And here, this is the continuation of the superior hypogastric plexus. You can find it here. It has a ganglion with the inferior mesenteric ganglion here. It has connective branches with the inferior mesenteric ganglion. And this superior hypogastric plexus conveys the sympathetic innervation to the pelvis, and it's formed by the thoracolumbar plankings at the caudal part of the inferior mesenteric artery. And the ureter lies at the lateral side of this region, attached to the ascending colon at the right side here, and attached to the posterior side of the rectosigmoid or descending mesocolon at the left side. And this retroperitoneal anatomical landmarks at the pelvis arises from the para-aortic region. The arteries come from here, the ureter comes from here. So as a continuation, we will take a look for the presacral area. This is the continuation of the para-aortic region. Here, para-aortic area, and this is the presacral region and part of the aortic area. Anterior to the sacral promontory here, between the rectosigmoid colon and sacrum. Here, this is the presacral space. We can call it also the retrorectal space because it's posterior to the rectum, retrorectal area. And this area is important for many major procedures, rectosigmoid resection, pelvic exenteration, also urogynecologic procedures, sacrocolpopexy, and also retroperitoneal lymphatic dissection, and also for the identification of the autonomic doors of the pelvis. Here, we are looking towards this area from a cranial point of view. This is the right common iliac artery, and this is the left common iliac artery. This is the left common iliac artery. And the ureter passes from the anterior side of the common iliac arteries. Number 10 at the left side and number 9 at the right side. So this X reveals the promontory level, and here between the common iliac arteries, we may notice the left common iliac vein. And anterior to the left common iliac vein, this is the superior hypogastric plexus, which I showed you from the previous slide, and it divides two parts. This is the right hypogastric nerve, and this is the left hypogastric nerve. The superior hypogastric plexus conveys the sympathetic innervation by means of hypogastric nerves towards the pelvic area. Here you can dissect these autonomic nerves from that region, and this X point reveals the sacrocolpopexy area at the anterior side of the promontory, which we anchor the suture to the anterior longitudinal ligament. So be careful about the common iliac artery at the right side, the ureter, and also the hypogastric nerve here. Why we anchor the suture to this point? Because at the left side, we may find the mesentery of the rectosigmoid colon. And dissection of this area is very difficult. Here you can see the left common iliac vein. Left common iliac vein lies at the posterior and medial side of the left common iliac artery. So this danger point at that area, and the mesenteric components like the inferior mesenteric artery here. So this is why we anchor the suture to the right side here. This area, presacral area, continues with the lateral spaces of the pelvis, paravesical space and the parietal space. Here, from the first side, I showed you the uterus lies at the middle side, anterior bladder and posterior rectosigmoid column. Para means lateral to. Paravesical means lateral to the bladder. Parietal means lateral to the rectum. So here, these are the avascular spaces in the pelvis, the continuation of the presacral space. Here, this is the paravesical space. And when we cut the peritoneum here, we may notice the anatomical landmarks of the paravesical and the paravesical and the parietal spaces. At the medial side here, attached to the broad ligament posterior leaf, we may find the ureter inferior to the ovarian vessels. And lateral to it, inferolateral to it, this is the internal iliac artery. This area between the ureter and the internal iliac artery is the parietal space. And at the anterior part, here between the visceral fascia of the bladder, the obliterated umbilical artery, the continuation of the internal iliac artery, which is the continuation of the internal iliac artery, the obliterated umbilical artery, attached to this perivesical fatty tissue, visceral fascia of the bladder. And this area at the medial side and laterally, the caudal end of the external iliac vessels reveals the borders of the paravesical space. And deeply, we may find the obturator internus muscle here and also the pubococcygeus at the medial side. These are the landmarks, main landmarks of the paravesical and parietal spaces. And if we dissect this area, we can identify the obturator nerve at the lateral side of the paravesical space. Here you can see the obturator nerve, which is passing inferior to the external iliac vein and exiting through the pelvis via the obturator canal, which is at the superolateral margin of the obturator foramen. The boundaries of this obturator foramen is the superior pubic ramus at the superior side and ischial bone at the inferior side. We will talk later about these issues. And this paravesical space is very important for pelvic lymphadenectomy and some urogynecological procedures. We can detail this information later. And this parietal space is very important to identify the ureter at the first dissection during the frozen pelvis cases or other procedures. And this is the another point of view for the parietal space. When we dissect the ureter here and lateralize it, we can notice the deeply lying autonomic nerves in the pelvis. This is the hypogastric nerve. You can find it. It's attached to the perirectal visceral fascia. And here at the lateral side, the pelvic splanchnic nerves comes from the dorsolateral part of the parietal space, lying obliquely towards the medial part of the parietal space. And we can continue our dissection that zone. And this is the total topographic view of the parietal and paravesical spaces. This is important for many pelvic procedures. I can talk later about the details about this issue. This is the right side of the pelvis. Here you can see the uterus at the middle side, the broad ligament posterior leaf, and the broad ligament anterior leaf here. And at the posterior side of the pelvis, the ureter is attached to the broad ligament posterior leaf, internal iliac artery, hypogastric nerve, which continues from the presacral space, and it lies at the lateral side of the rectum, attached to the perirectal visceral fascia at the inferior part of the ureter. To find this hypogastric nerve, first you must find the ureter, dissect the parietal space, and isolate the hypogastric nerve at the inferior portion of the ureter. And laterally here you can find the pelvic splanchnic nerve, which is responsible for the parasympathetic innervation in the pelvic cavity. And these nerves arise from S2 and S4 at the medial side of the internal iliac vein, and they lie obliquely towards the hypogastric nerve, and they merge and form the inferior hypogastric plexus at the medial side. Here you can see this is the parietal area, and the anterior boundary of the parietal space is the parauterine and paracervix tissue. The parauterine tissue is the continuation of the uterine artery with the lymphatic tissue, which is lying at the superior side of the ureter, and this is inferiorly lying area is the paracervix tissue. It lies at the inferior part of the ureter, and this area is rich for pelvic autonomic nerves. And this anterior portion of the pelvis is the paravesical space. The obliterated umbilical artery divides the paravesical space into two parts. When we dissect the obliterated umbilical artery and lateralize it from the prevesical fatty tissue, here you can find it, the obliterated umbilical artery. When we dissect it and lateralize it, it divides the paravesical space into two parts, the medial and lateral. The lateral part, here we find the obturator nerve, which is responsible for the adduction of the thigh, and it lies at the inferior part of the external iliac vessels. So this paravesical space, medial paravesical space, is important for parametrectomy or radicalisectomy or nerve sparing procedures, and the lateral side is useful during pelvic lymphadenectomy or other lateral pelvic wall procedures. And this parietal space is important for nerve sparing procedures, even in endometriosis, uterosacral nodule excision, or other types of surgeries. And this is the prevesical space. Pre means anterior to the bladder. Prevesical is the prevesical space anterior to the bladder between the pubic bone and the bladder. Here you can see. Then we dissect that area and leave the fatty tissue, this yellow fatty tissue, at the anterior part of the bladder. It belongs to the bladder. The fatty tissue is a supportive mechanism. It's also, we can find it also at the anterior and lateral side of the rectum. And also, for example, at the upper abdomen, we can find the omentum as a supportive tissue for the stomach, like that. So we let this yellow supportive tissue anterior to the bladder and make our dissection just posterior to the pubic bone. This is the safe area to develop the prevesical space, and deeply we may find the arcus tenuis fascia pelvis. This arcus tenuis fascia pelvis forms the pubocervico-vaginal fascia. It's important for paravaginal support mechanism. It lies between the obturator internus muscle and pubococcygeus. It's a part of the levator ani, and so the condensed fascia between these muscles forms the arcus tenuis fascia pelvis. And if there is a detachment of this fascia after labors or some surgeries, pelvic surgeries, we may find a paravaginal hernia. We may diagnose a paravaginal hernia for this patient. This is the urethra, which is lying at the anterior part of the vagina. Here you can see at the anatomical position, surgical supine position, at the superior level of the vagina, we will find the urethra here. And during vertical post-suspension, we put the sutures to the vaginal level and also towards the superior pubic ramus. I can detail the information regarding the coronomortis vessels and the superior pubic ramus later. And this is another space in the pelvis. You may find that laterovascular plane means that lateral to the vascular planes, laterovascular plane. External iliac artery and external iliac vein, you can see them. When we detach these external iliac vessels from the psoas major muscle, we may find the obturator nerve here, which is emerging from the psoas major muscle at the common iliac vessel level, pelvic brim level, and inferior to the obturator nerve. Here you can find the lumbosacral trunk. It's the major component of the sciatic nerve, and it merges with S1, S2, and S3. And this area is important for paracervical lymphadenectomy, for endometriotic nodular excision. And this lumbosacral trunk forms the sciatic nerve by merging S1, S2, and S3. If there is an injury here, the patient will have a drop foot, and also between the obturator nerve and lumbosacral trunk, we will find the iliolumbar vessels. These iliolumbar vessels drain into the internal iliac vein. And if we injure these veins, we may rupture the internal iliac vein, and there will be a gross amount of bleeding at that zone. It's very dangerous. And the next figure, the next figures are related with the neurovascular anatomy of the paraortic and pelvic retroperitoneal area. I will select some figures and show you them. Later, we will continue with the videos. This is the external iliac artery anatomy. But first of all, I try to explain you the avascular spaces, because if you understand the topography of the avascular spaces, you will be familiar with the vessels, nerves, and the ureter, and also the parametria. Afterwards, you will understand the detailed anatomy of the vessels and the other structures. So we will continue. Now we will continue with the detailed anatomy of other structures. Now we start with the external iliac vessels. Right side of the pelvis, psoas major muscle, external iliac artery, beneath, just attached to the psoas major muscle, and posterior and medial to the external iliac artery. This is the external iliac vein, and this is the caudal part, end part of the external iliac vessels, just at the level of the inguinal ligament. And this is the lateral side of the paravesical space, and inferior to the external iliac vein, we will find the obturator nerve. These are the branches of the external iliac vessels, related branches of the external iliac vessels. And the tip point for these structures are, the tip point for these structures is, there is no vessel at the anterior or lateral or medial side of these vessels to the level of the inguinal ligament. Inguinal ligament is formed by the caudal, by the extensions of the external oblique muscle. Here you can see the inguinal ligament, and laterally deep circumflex iliac vein passes from the anterior side of the external iliac artery and drains into the external iliac vein. This is a landmark for the end point of pelvic lymphadenectomy. And here we can see the deep circumflex iliac artery is accompanying to the vein. And this deep circumflex iliac artery has anastomosis with the supergluteal artery. The supergluteal artery is a branch of the internal iliac artery, and don't forget this anastomosis. I will explain it later. And this is the inferior epigastric vessels. These are responsible for the blood supply of the infraumbilical region, deep infraumbilical region. The blood supply is inferior epigastric vessels. This artery arises from the caudal part of the external iliac artery and lies obliquely medial towards the umbilicus level. So here, this is important for lateral trocar entry. I will explain it later also. And this is the anastomotic branches which are lying over the superior pubic ramus. These pubic anastomotic vessels may have may arise or arise from the external iliac artery or drain into the external iliac vein, or may be related with the inferior epigastric vessels. But these pubic anastomotic vessels also, they are related with the obturator vessels. So that's why we call them coronomortis vessels. These coronomortis vessels lie over the superior pubic ramus. And during a retroperitoneal approach, during a retroperitoneal surgery, if you develop this area from the pelvis, you may find these vessels directly in front of you. And if you find these vessels directly in front of you, it's not a danger point during retroperitoneal surgery from a pelvic point of view. But if you perform a surgery from the inguinal area and dissect this area from the retrograde portion, from the inguinal region, you may not notice them. I will show you. 2 days ago, we had a surgery like that during an inguinofemoral lymphadenectomy, and we find the inferior epigastric vessels here. But not from this point of view, from an inguinal point of view. And if there will be an injury from that exposure, it will bleed and cause a problem for us. But from this point of view, they won't cause any problem because we notice them, and if they bleed, we will coagulate them or suture them. These are the coronomortis vessels, and here I will explain you the other figure. During vertical suspension, here we put the sutures, anchor the sutures at that iliopectineal ligament, to this pectineal ligament, Cooper's ligament. And these coronomortis vessels lie at the proximal part of this area. So they have no connection during that surgery, even during TVT. You are very far away from these branches. Here you can see this is the area, the arcus tendons fascia pelvis, and this is the area where we pass our TVT trocar. So it's very far away from the coronomortis vessels. And for the TOT procedure, we don't encounter to this prevesical zone. We will be just beneath, inferior to this pelvic diaphragm, pelvic floor level. We will be at the inferior region of this area. We don't enter the prevesical space, so there will be no problem during TOT also. This is the anatomy of the external iliac vessels. And don't forget that the tip is the branches related with the external iliac vessels lie at the inguinal ligament level. And they are important for urogynecologic procedures and radical pelvic surgeries. And this is the branches related with the internal iliac artery. This is the right side of the pelvis. This is the pubic bone level, caudal part here. This is the right side, pars major level. If you are lost in the pelvic cavity, first of all, find the promontory, find the pubic bone. Pubic bone is here, superior pubic bone. So this is the anterior. This is the promontory level, posterior. You can see this area is the promontory. This is the psoas. Psoas lies at the lateral side of the pelvis. So at the right lateral side, this is the right pelvic cavity. External iliac arteries, here you can see common iliac artery and ureter attached to the broad ligament posteriorly. This is the internal iliac artery arising from the iliac bifurcation. And lateral to the internal iliac artery, we may find the external iliac vein. Inferior to the internal iliac artery, we may find the internal iliac vein. And during internal iliac artery ligation, be careful about the external vein at the lateral side. Be careful about the internal vein at the inferior side. When we follow the internal iliac artery, the first anteromedial branch is the uterine artery. Here you can find it. And when we continue this area, this is the longitudinal continuation of the internal iliac artery, obliterated umbilical artery. And after the uterine artery, distal to it, we may find the superior vesical artery. But at the inferiorly arising branches from the internal iliac artery, the first inferiorly arising branch is the superior gluteal artery, a major branch of the internal iliac artery. Later, we may find the inferior gluteal artery and also the vaginal artery. And here, I will comment on the superior gluteal artery. Superior gluteal artery is the dominant branch, but what I said is that here, this deep circumflex iliac artery of the external iliac artery have anastomosis with the superior gluteal artery at the iliac crest level. iliac crest level, close to the iliac bone, and they supply the gluteal vessels. If a patient has no vascular problems, no preeclampsia, no disseminated intravascular coagulation, or no previous surgery which obliterates the internal iliac vessel system or other related vessels, or no radiotherapy history, this patient will have no problem even if you close or suture this internal iliac artery at the proximal level or distal level. That patient will have no problems because of the anastomosis. But if there's a disseminated intravascular coagulation, a major bleeding during the surgery, or preeclampsia vasoconstrictive pathology, that will be a problematic for the patient. And after these conditions, the patient will have a problem. Why this internal iliac artery ligation is not useful? Why we call that it's not good during the surgery? That's a bias situation. That's a time bias and surgical practice bias. We do this internal iliac artery ligation at the end of the surgery because it's you must improve your skills for this internal iliac artery ligation. It's a complicated anatomy. The patient is bleeding, and there are many closed veins here, and they can be injured during surgery. And there's a problem. The patient is bleeding, and the room is crowded. There's a hemorrhage, and we do this surgery, this internal iliac artery ligation, at the end of the surgery, even after trying everything, as a rescue issue. But don't do this as a rescue issue, because at that time the patient has disseminated intravascular coagulation or other problems. So it cannot stop the bleeding. You cannot predict that the internal iliac artery ligation will be helpful during that condition, because the patient no blood supply, no blood residual blood in the blood system, and no coagulation systems. Even if you close this internal iliac artery, it can be not helpful to decrease the bleeding. But if you perform this ligation at the beginning of the surgery, after uterine artery ligation, it will be, I believe that in our surgical practice, we know that it will be helpful, because the DIC didn't happen, and the patient is good in condition. There's no shock symptoms, and this internal iliac artery ligation will decrease the blood supply for the pelvis, but do it bilaterally. So this is the physiologic anatomy for this internal iliac artery ligation, and we suggest doing that at the beginning part of the surgery after uterine artery ligation or sutures for the uterus or other conditions. And later I will talk other management issues of pelvic hemorrhage by videos. This is another point of view for the pararectal and paravesical spaces. Here you can see the complex anatomy of the lateral parametria. Between the paravesical space, this is the right side of the pelvis. Here you can find the external iliac artery at the right side, the ureter at the medial side, and here the paravesical space at the anterior portion and the pararectal space at the posterior portion. Ureter, and inferior to the ureter, the hypogastric nerve. And this is the internal iliac artery. This is the pelvic splanchnic nerves. They merge at the medial side of the paracervix. This is the uterine artery, which is passing from the superior side of the ureter. And inferiorly, this area between the paravesical and the pararectal space is the lateral parametria. From the superior side to the inferior side, the components of the lateral parametria are uterine artery and related lymphatic tissue, the ureter. The veins accompanying the paracervix here, the deep uterine vein, vaginal vein, and also inferior to the veins, the hypogastric nerve at the medial side, and at the lateral side, here you can see the pelvic splanchnic nerves, and inferior hypogastric plexus, the pelvic ganglion here at the medial side of the paracervix. So this lateral parametria has a complex anatomy, and be careful about the veins. The arteries are not problem. The veins are problem, because they have anastomosis, many anastomosis in the pelvis, and they are the red alert zone. And the most important part is the vesicovaginal anastomotic veins, and they drain into the internal iliac vein. I will show them to you with another figure, and later we will talk with the videos. This area, why this area is important, I will explain you that with the parametria, nerves, and also the vessels. Again, this is the posterior side of the pelvis. Now we talk about the vessels, guys. Dear colleagues, we talk about the vessels. First, spaces, second, vessels, partially nerves, and now we will talk about the ureter, nerves, and parametria, the main ligaments of the pelvis. This is the uterus and posterior rectosigmoid column. We developed the parectal space lateral to the rectum, and between the vagina and the rectosigmoid column, the rectovaginal space. We cut the peritoneum, here you can see, and this is the rectovaginal space. And this is the ureter. Here you can find it, external iliac vessels. We lateralize the ureter, and this is the medial parectal space. We find the hypogastric nerve inferior to the ureter. And at that zone, medial to the ureter and hypogastric nerve, this is the uterosacral ligament between the uterus and sacrum, deeply lying towards the sacrum at S3 and S4 vertebral level, between the rectum and vagina. And that's why we call it superficially rectouterine and deeply rectovaginal ligament. This is the uterosacral ligament. And modern anatomy, we call it rectouterine and rectovaginal ligament. So during nerve sparing procedures or uterosacral ligament excision or endometriotic surgeries or nerve sparing radical hysterectomies, we develop the medial parectal space, lateralize the ureter, find the hypogastric nerve. We develop the rectovaginal space, identify the uterosacral ligament here, and dissect the hypogastric nerve from that zone. And then later we can resect this uterosacral ligament or nodule here. And be careful about this medial zone of the hypogastric nerve here, the deep rectovaginal component, because the inferior hypogastric plexus lies here. And even if you preserve this proximal part, if you don't preserve this deep end part, distal part, inferior hypogastric plexus, you may have an injury. This is the posterior parametria at the ureter level, pararectal level. And when we cut the uterine artery here, this is the right side again, external iliac vessels and internal iliac artery. This is the ureter. And when we cut the uterine artery from the internal iliac artery, this is the first anteromedial branch. And mobilize the medial paracervix here with the connective cellulolymphatic tissue from the superior level of the deep uterine vein. This is the parauterine and medial paracervix tissue. And this is the vesicouterine tissue, another component. I explained the lateral parametria between the paravesical and the parectal space. But this lateral parametria, parauterine and paracervix tissue, which we call that in modern anatomy, but historically we call that cardinal ligament. This is the cardinal ligament, but indeed it has no suspensory function. It is a cellulolymphatic tissue. Here you can see I explained and I showed the anatomy here: uterine artery, lymphatic tissue, ureter, uterine veins, and also the nerves. There's no ligamentous tissue like the uterosacral ligament. Here you can see it's a fibrous tissue and it has suspensory functions. But this cardinal ligament, historically, now the parauterine and paracervix tissue, has no suspensory function. But the most importantly, the main issue is that this parauterine and paracervix tissue has connections with the vesical uterine tissue. Another terminology here, the connective tissue between the bladder and the uterus, vesicouterine. We developed this area by identification, by dissection of the medial paravesical space and also the vesicovaginal space. Between them, this is the vesicouterine tissue, and it has connections with the parauterine tissue. When we dissect this area from the superolateral part of the ureter, because the superolateral part is avascular or the superomedial, but at the anterior side to 12 o'clock position, we may notice vessels here connected with the uterine artery or uterine vein. Here, when we develop this area from the superlateral angle and dissect that superficial, the parauterine and vesicouterine tissue, we can detach the ureter from the lateral side of the upper vagina. And this area is the yabuki space, the fourth space. It's indeed another space. There are two main spaces, paravesical and pararectal spaces. This is a dissection plane, but we call it a space. Yabuki called that, also the Okubayashi. This is the medial side of the ureter. We identified this area after total parametrial dissection, total suprauteric parametrial dissection. This is the inferior and medial side of the ureter, vesicovaginal ligament. And deeply, we can find the autonomic nerves here, the continuation of the hypogastric nerve. And when we dissect this vesicovaginal ligament, we can notice here the bladder, right side, the ureter, bladder base. We dissected all the parametria. This is the hypogastric nerve, pelvic splanchnic nerves arising from the medial side of the internal iliac vein, merging with the hypogastric nerve and forming the inferior hypogastric plexus at this zone. And they are giving branches towards the bladder base. Here you can see these are important for the bladder functions. And this is the lateral paracervix. And this anatomy by starting from the spaces, from the superficial area to deep area. My advice is that, my suggestion is that first develop the spaces, make a dissection from the superficial area towards the deep area, layer by layer, and identify the next upcoming anatomical structure. Otherwise, you may have a huge amount of bleeding during radical pelvic surgery. Here I showed all the elements, all the anastomotic branches here. And this is the autonomic nerves in the pelvis. As I said, spaces, arteries, ureter, pelvic connective tissue, parametria, and deeply the nerves. They are close to the pelvic floor level, levator, ani. And even if you preserve the hypogastric nerve or the proximal parts, if you don't preserve the target branches and branches towards the bladder or rectum, you may have functional loss. You may have a functional loss. And this is the lateral paracervix. Here, this is the lateral side of the paracervix. And we call this area the cardinal ligament, this deep side of the cardinal ligament. Here you can see it's indeed a cellular lymphatic tissue. When we dissect it also, here this is the iliococcygeus and pelvic floor level. We don't notice any suspensory function here. The cellular lymphatic tissue is totally dissected. Here you can see the psoas and promontory level, and this is the pelvic floor level. And we dissected all the zone. Here S2, S3, and S4, hypogastric nerve, inferior hypogastric plexus, and bladder nerve branches, and pelvic floor. There is no laterally suspensory function. And this is the total pelvic dissection, and this is the internal iliac vein at the medial inferior side of the artery. And again, so everything, my advice is that if you are going to perform a radical pelvic surgery, pros and pelvis, or identify something important in the pelvis, here, this is the beginning part. The parietal space or retroperitoneal dissection. Identify the psoas, follow the external iliac artery, find the ureter at the inferior part of the ovarian vessels at the promontory level. This is the promontory level, this is the ureter. When you find the ureter, you may find the hypogastric nerve, you may dissect the parietal zone. And this is, for example, this is the inferior hypogastric plexus at the parietal area, rectal branch, uterine nerve, and bladder nerve branches. So for nerve sparing surgeries or other procedures, the pararectal space is very important. And now I'm going to show you just one figure, and later I will show you the videos. This is the anatomy of the parametria, vascular anatomy of the parametria. Here you can see, guys, the right side of the pelvis. Psoas, external iliac vessels, bladder, uterus, vesicovaginal space. This is a cadaveric dissection. This is the ureter. Running towards the bladder base. This is the hypogastric nerve and bladder nerve branches. Here, this is the uterine artery, the parauterine tissue, and the vesicouterine tissue, which I showed you at the parametrial figures. This area is covered by the cellular lymphatic tissue. When we dissect that zone, at the superlateral part of the ureter here, you can find this uterine artery and connective anastomotic branches here, veins, vesicovaginal venous anastomosis, draining towards the internal iliac vein at the deep side of the ureter, here, the deep side of the ureter. So any blunt dissection here, any heart movement here will cause you a huge amount of bleeding. So be careful about the parametrial dissection. It's not very easy, but if you know this anatomy, if you know these branches, it's not a problematic issue. Now I will show you a few videos. Later we can continue with figures also or other things. First of all, I will talk about the uterine artery ligation. It's important and how we do it. I think you can see the screen. Okay. Here, the uterine artery, the right side, this is the right side. The uterine artery is the first anteromedial branch of the internal iliac artery. Psoas, external iliac vessels, internal iliac artery, ureter parietal space, and obliterated umbilical artery, medial paravesical space, obturator nerve, lateral paravesical space. Here you can see the first anteromedial branch, the uterine artery. So we use this anatomy for ligation of the uterine artery. This is the ureter. Here you can see the uterine artery is passing from the superior side of the ureter. And there's an avascular zone at the superolateral area of the ureter. This is the parectal approach, broad ligament posterior leaf level. This is a big uterus. Here you can see there's a corpus tumor here, corpus endometrial tumor. We don't use any intrauterine manipulators. It's difficult to mobilize the uterus. This is the appendicis epiloica. We mobilize the rectosigmoid colon from the appendicis epiloicus. We can use tail lift or suture traction at that zone. This is the promontory level, ovarian vessels, and inframedial to the ovarian vessels, the ureter, and this is the common iliac artery level. We cut the peritoneum between the ureter and ovarian vessels, just inferior to the ovarian vessels, make a dissection towards the retroperitoneal area, identify the ureter at the medial branch of the broad ligament, posterior leaf, attached to it, and laterally, we can notice the internal iliac artery and the first anteromedial branch. This is the uterine artery. It has a tortuous lie, and it's very easy to find the uterine artery, identify the uterine artery because of this tortuous line. Ureter and the uterine artery. Secure the uterine artery for thermal injury, secure it, make a dissection cleavage between the ureter and the uterine artery and ligate it. It's very easy. Another approach, round ligament, promontory, right side, common iliac artery, ureter, infilopelvic ligament, lateral pelvic peritoneum, here you can see, the obliterated umbilical artery, rectus abdominis muscle here. And we cut the peritoneum between the round ligament and the infilopelvic ligament. We make our dissection towards the cranial part, parallel to the ovarian vessels, infilopelvic ligament. And when we enter the retroperitoneal area, we may find the external iliac artery attached to the psoas major muscle at the medial side. When we follow the external iliac artery and pull the broad ligament posterior leaf towards the sacrum, we will find the ureter at the inferior part of the ovarian vessels here. This is the promontory level. When we make a dissection at the lateral side of the ureter, here you can find the internal iliac artery, lateral to the inferior to the ureter. Continue your dissection at the anterior side of the internal iliac artery, as like external iliac artery. At the anterior side, 12 o'clock zone of the internal iliac artery, there is no branch, no vascular branch. Use this anatomy during your dissection. Follow the internal iliac artery. The first anteromedial branch is the uterine artery. It's very easy to identify the ureter and the internal iliac artery. Make a superficial dissection at that zone from the anterior side of the uterine artery and posterior side of the uterine artery, and secure the ureter by this dissection for thermal injury and ligate it. Very easy. I mostly prefer this method. I will explain that why. And this is the paravesical approach. It's a bit difficult, but know this anatomy and use all the anatomy for your cases. Because as I explained to you from the spaces, the presacral space at the posterior side, continuing with the parietal space, continuing with the paravesical space, continuing with the prevesical space. All the spaces are interconnected. Use this anatomy and identify the anatomical structures. Now the prevesical space, the round ligament, the anterior part of it, the bladder, lateral to the bladder, the prevesical space. You don't need to cut the broad ligament. Lateral to the external iliac vessels, make a dissection towards the avascular zone. Here you may find the paravesical space. This is the first arising thing, whitish tissue, but it's just inferior to the external iliac vein. So think that the inferior to the external iliac vein, there is an obturator nerve. And this is the obturator nerve. And it's covered by the cellular lymphatic tissue, the lymphatic tissue, pelvic lymph nodes. And detach these nodes from the medial side, from the bladder level. And here, this at the medial side, the bladder level, we detach these lymph nodes from the bladder level, from the visceral fascia of the bladder. Here you can find that. This is the obliterator umbilical artery, continuation of the internal iliac artery, and this is the paravesical space. If you detach the lymph nodes and you make your dissection towards this area, if you detach these lymph nodes, you may have a bleeding during this dissection. These nodes are avascular, don't forget that. If you have a bleeding, you are at the wrong space. You are at the wrong plane. You are at the wrong plane. And here you can see that this is the internal iliac artery, ureter, parietal space. Internal iliac artery, the longitudinal continuation is the obliterator umbilical artery. If we hold this obliterator umbilical artery and detach it from the visceral fascia of the bladder, this is the first branch from the paravesical space. This is the superior vesical artery here, not the uterine artery. From this approach, from the paravesical approach, the first branch is the superior vesical artery. If we continue our dissection from that one, this is the uterine artery. The first anteromedial branch from the parietal space is the uterine artery, and after the uterine artery, distal to it, we may find the superior vesical artery. But from the anterior point of view, if you make a dissection, retrograde dissection from the anterior side, the first branch is the superior vesical artery, the second branch is the internal iliac artery. And during this dissection, from the paravesical area, we will find the continuation, the distal part of the internal iliac artery, not where the internal iliac artery arises here. Here, this is the uterine artery. And this is the parauterine lymphatic tissue. This is important for sentinel lymph node dissection, the supraureteric lymphatic pathway, which is accompanying the uterine artery. We can divide this tissue here. When we divide this tissue, you can find that there is no branch here at the anterior side of the internal iliac artery. We use this anatomy and we make our dissection according to this anatomy. Here you can find that the first anteromedial branch is the uterine artery. So it's all the time the anatomy. If you know the anatomy very well, and if you improve your skills by practicing at home or practicing at dry labs, you will be very good during the live surgeries. And this is the left side. I will explain you another thing. I will explain you another thing. This after hysterectomy. This is the psoas major level. This is the broad ligament posterior leaf. When we pull the broad ligament posterior leaf towards the sacrum and we continue our dissection towards the medial side, just close to the external iliac vessels. This is the external iliac vessels with the lymphatic tissue. It's a bit difficult. But you must also know this very well. And here, for the obese patients, there will be some bleedings because of this fatty lymphatic tissue. and we find this ureter and the uterine artery from the parietal area. And if we pull the broad ligament posterior leaf towards the sacrum, and we will find the ureter attached to the broad ligament posterior leaf. This is the ureter at that zone. This is the parietal area. We dissect that zone. Here, the internal iliac artery. It's a bit difficult if you are not very familiar with that anatomy. Now I am changing the direction of the camera, and here you can see the first anteromedial branch. This is the uterine artery. And this is the obliterated umbilical artery, distal to the uterine artery. And here, another point of view, it's a bit difficult to dissect the uterine artery here from the anterior and posterior part and isolate it. So you can ligate it from the umbilico-uterine branch here. It has no problems, no comorbidities, or no complications. As I showed you, you can ligate the umbilico-uterine branch from here. You can ligate it from here. No problems. You will sacrifice the superior vesical artery, but no problems. So my point of view, my suggestion is the parietal approach, and you can find the external iliac artery, follow it to the promontory level, and develop the parietal space and find the uterine artery. Just a second, please. Hello again. Now, after the uterine artery ligation, I will show you a few more things. I will show you laparoscopic entry techniques. I always prefer open entry. And this patient has a previous vertical incision, both infraumbilical level and at the supraumbilical level, and has a left-sided colostomy. So we didn't use the left subcostal entry, we used the right subcostal entry. But if you use open entry, you will have no problems. I will really say that you will have no problems because you dissect all the layers step by step, and you find everything upcoming towards you. For example, sometimes we dissected from the left side, even there's no surgery, even it's far away from the previous scar. But at that point, the tip is that be far away from the previous scar. Be far away from the previous scar. This is the main issue. If you are far away from the previous scar, you will have no problems. And here you can see our dissection. I will infraumbilical and supraumbilical incisions. This is the colostomy. And at the right side, supraumbilical region, there's a falciform ligament here. And if you are very close to the midline, you will just enter to the falciform ligament at the right side. So do your incision at the subcostal region, midclavicular line, here. Skin, fatty tissue, Camper's fascia, later scarpa's fascia, and the whitish tissue of the rectus fascia. Use parabefs. Hold the rectus fascia, cut it, and this is the rectus muscle. And if you are lateral to this area, you will find the external oblique and transversus muscle. And at the midline, 4 or 5 centimeters beyond the midline, you may find the rectus muscle here. You can dissect the rectus muscle here, no problem. But at the infraumbilical region, be careful about the inferior epigastric artery. When you cut the rectus fascia and dissect the rectus muscle, you will notice a inferiorly lying fascia, the posterior fascia of the rectus muscle. Hold it, but don't hold it with a forceps with a tooth. You may injure, if there is an injury here, if there is a serosal attachment of the intestines, you may hold the intestines with the forceps, with a tooth forceps, and you may injure that. Use a non-traumatic forceps, hold the fascia, and cut it with scalpel. Now you are in the abdomen. You see? You are in the abdomen. No problem. To prevent gas leakage, suture this tissue, suture this fascia, insert your trocar, and after insertion of your trocar, also suture the skin. This is the suturation of the rectus fascia. And later, when you put your trocar, suture the skin also. This is not for the leakage of the gas, also for the point of the view, because the other environment, the outer environment is cold and the abdominal pelvic cavity is hot. And when you push your camera there, there will be a different point of the temperature for the gas, and that will obscure your point of view with the camera, and you have a blurred point of view. So suture the skin here, and so you will prevent a gas leakage and also secure your camera. Now I will show you a video about identification of the posterior parametrium during endometriosis surgery, because it's very important and many of our colleagues are performing endometriosis surgery. And most of the time, the endometriotic nodules are noticed at the uterosacral ligament level. So this is how we develop this area. This is the right side of the pelvis, pelvic brim level, ureter, ovarian vessels. And here, inferior to the ureter, we cut the peritoneum. This is the attachment line of the uterosacral ligament here. Between the ureter and the uterosacral ligament, we cut the peritoneum. We use energy slightly. And lateral to this area, this is the hypogastric nerve. This is the hypogastric nerve, inferior to the ureter, as I mentioned. Continue your dissection towards the posterior part of the cervix. This is the attachment of the uterosacral ligament, a fold. Here, the lateral zone, the hypogastric nerve is lying at that zone. And this is the rectouterine fossa. I'm showing that dissection. Here, the ureter and the uterine artery. When we cut the peritoneum, we may find the zone of the uterosacral ligament. This is the fibrous attachments of the uterosacral ligament. But during this nodular excision or uterosacral ligament excision, if there is no tumor here, preserve the hypoglycemic nerve. If there is a tumor attached to that zone, you cannot preserve the hypoglycemic nerve. But if there is no tumor lateral to that zone, inferior to the ureter, here lies the hypoglycemic nerve. You can detach this hypoglycemic nerve by using suction. Here, we identify the proximal part of the hypoglycemic nerve. Sometimes we use the energy and sometimes we use the suction and lateralize the hypoglycemic nerve from the uterosacral ligament. These are the fibrous attachments. When we lateralize the hypoglycemic nerve, this is the zone. Here you can see between the uterosacral ligament and the hypoglycemic nerve. And we are now developing the rectovaginal space. Here, attachments between the vagina and rectum. Here, this is the rectovaginal septum. This is the rectovaginal septum. Fibrous attachments. Denon-Wheeler's fascia, elements of the Denon-Wheeler's fascia. And here you can see the rectovaginal septum. We didn't develop the rectovaginal spaces totally. We just developed the lateral part of the rectovaginal space close to the uterosacral ligament, and we didn't detach the rectovaginal septum totally. And this is the uterosacral ligament, the rectouterine and rectovaginal portions. At the lateral side, the hypoglycemic nerve here, this is it, we lateralize it. And this is the fibrous attachment of the uterosacral ligament. This is the approach during endometriotic nodular excision or surgery. And now I'm going to show you a few figures related with the vascular anatomy of the lateral parametria. Just a second, please. Here, I will show you. Yes, this is the pararectal and paravesical space. Right side, paravesical space, medial side, lateral side, obturator nerve, pararectal space, internal iliac artery, and ureter. Hypoglycemic nerve, pelvic splanchnic nerves, medial to the internal iliac vein, and this is the lateral parametria. At the superior part of the ureter, the uterine artery, and accompanying it, the superficial uterine vein. But deeply, there are many veins, anastomotic veins. Be careful about these veins during ureteric dissection. When we cut the uterine artery and the superficial uterine vein from the superior side of the ureter, and these anastomotic veins, deep uterine vein, vaginal vein, are draining into the internal iliac vein. And even during this supraureteric dissection, you may injure these veins, infraureteric veins. When we cut the supraureteric tissue parametria totally, and we can find these veins, vesicovaginal veins, anastomotic veins, are draining into the internal iliac vein, and this is the pelvic autonomic nerves here. And this is the pelvic floor level. So the pelvis has a complex neurovascular anatomy. Be careful about the neurovascular structures. And this is the arcus tendineus fascia pelvis, coronomortis anatomy. Right side, again, paravesical space between the pubic bone and bladder. The paravesical space, the caudal part of the external iliac vessels, superior pubic ramus, vagina, and urethra, pubourethral ligaments. Pubic bone, superior pubic ramus, obturator internus muscle, obturator nerve, external iliac vein. Here. Between the obturator internus muscle and pubococcygeus and iliococcygeus, this is the arcus tendineus fascia pelvis at the lateral side of the mid vagina, and vagina is attaching to this arcus tendineus fascia pelvis. And after delivery, that's why paravaginal hernia occurs. The detachment from arcus tendineus fascia pelvis may causes this problem. It's a support mechanism for the pelvis. And this is the superior pubic ramus, and this is the iliopectineal ligament level. And proximal to it, the anastomotic vessels here, these are the coronomortis vessels between the inferior epigastric, external iliac vessels, and the obturator vessels. And they enter the obturator canal at the medial side of the obturator nerve here. These are the coronomortis vessels. This is the femoral nerve. I will show it to you later at the right side. When we cut the iliopsoas fascia between the psoas major muscle and iliacus muscle, and when we medialize the psoas major muscle, we will find the femoral nerve here. This is the femoral nerve, and this branch, this nerve, which is lying at the anterior side of the psoas major muscle, this is the genitofemoral nerve. It has just sensory functions in females. I will show you the pudendal nerve and later just one video. And this is the left side. This is the left side. Here you can see the anatomy, psoas major muscle, external iliac vessels, obturator nerve. This is the obturator fascia. When we cut the obturator fascia, here this is the lumbosacral trunk coming from L4 and L5. Just inferior to the obturator nerve. Internal iliac vessels here, internal iliac artery, sacrum level. When we cut the internal iliac vessels or lateral to the internal iliac vessels here, this is the supraegluteal artery. Here you can see between the lumbosacral trunk and S1. This is S1. This is S2. And they are passing just inferior to the obturator fascia. When we dissect this obturator fascia, here you can see, again, the same anatomy. Obturator nerve, lumbosacral trunk, S1, S2, piriformis muscle, and S3, and pudendal nerve. Now, pudendal neuropathy is very, I'm coming with the videos of this pudendal neuralgia or symptoms of that. This is the ischial spine level, and this is the pudendal nerve. Here, there will be some endometriotic nodules and scar tissues at this ischial spine level. But for the release of the pudendal nerve here, you may dissect the anterior portion of the ischial spine, the perineal level, because it passes from that zone inferior to the ischial spine and lies towards the perineum from the lesser sciatic foramen. It's a bit complicated anatomy, but pudendal nerve entrapment, the surgery towards this area is performed from that zone. From the anterior level of the ischial spine here. And at that area, we may also find the sacrospinous ligament, this number 8 is sacrospinous ligament. It attaches to the ischial spine, and we will find it at the perineum level. This is the coccygeus muscle. When we cut it, we will find the sacrospinous ligament. And inferior to this sacrospinous ligament, the sacral nerves pass from that zone. This is a bit complicated anatomy. Now, I will show you a video, and we may discuss the anatomical structures with that video. This video is not edited, so you can understand everything. It's totally 20 minutes. but maybe I can show ureteric dissection or also. Just a second. Here, this is the posterior parietal peritoneum between the rectosigmoid colon and small intestines. We cut the peritoneum here. And posterior to the rectum, attached to the perirectal fatty tissue, we may find the superior hypogastric plexus here. Use the energy carefully and sometimes perform tiny dissections. This is the whitish tissue of the superior hypogastric plexus. Here you can see that we are dissecting the superior hypogastric plexus. This is the first step during nurse sparing procedures to identify the superior hypogastric plexus. And be careful about that during sacrocolpopexy procedures also. And here you may understand that this is the presacral area, presacral space at the retrorectal zone. And this superior hypogastric plexus is dividing into the right and left hypogastric nerves, which conveys the sympathetic innervation towards the pelvis. And from this presacral space, it's traveling, running towards the pararectal, medial side of the pararectal space. Here, this is it. The ureter is lying at the lateral side. Now, I will show you another video. Most of the time, I cut the peritoneum to enter the retroperitoneal area. I cut the peritoneum between the round and infilopelvic ligament. I make my dissection towards the pelvic brim level. This is another patient, not the same as the uterine artery ligation. If you detach the peritoneum as much as possible, you may find an improved exposure. Pull the broad ligament posteriorly, medially, find the ureter, as I mentioned, lateral, inferolateral to the ureter. This is the internal iliac artery. Follow the internal iliac artery. Find the uterine artery. Develop the superficial part of the paravesical space. This is a non-edited video, so you may understand the difficulties during the surgery. Dissect the parietal space deeply. During dissection of a space, first enlarge the field, because if you dissect the space from a narrow point of view, and if you have a bleeding, it's difficult to manage it. But firstly, enlarge the superficial part, then go towards the deep part. So if you have a bleeding or a problem, you will manage it easily. This is the uterine artery here. These are the subperitoneal tissues. We dissect them, loose tissues, loose areolar tissues. I dissect them towards the paravesical space, internal iliac artery, lateral side of the internal iliac artery here. This is the obturator artery. Medial side of the internal iliac artery, lateral zone, dorsolateral zone. At that zone, I will find the pelvic splanchnic nerves, and at the medial zone, I will find the hypogastric nerve. I'm dissecting the parietal space deeply and cutting some fibrous attachments. Internal iliac vein level, paracervical lymph nodes, the yellow ones, using suction here. And suction reveals the tiny branches of the autonomic nerves effectively. These are the pelvic splanchnic nerves. I detach them from the paracervical lymph nodes from the medial side of the internal iliac vein here. These are the tiny branches of the pelvic splanchnic nerves, parasympathetic innervation, which are responsible from the parasympathetic innervation. Here you can see them. Be careful during these dissections, otherwise you may have great, huge bleedings or complications. We do this kind of dissection during type C2 nerve sparing radical hysterectomy. It's not necessary all the time during type C1 nerve sparing procedures. Pelvic splanchnic nerves at the dorsolateral part, and at the medial side, the hypogastric nerve. This is it. Suction dissection is very beneficial at that zones most of the time. And don't use thermal energy all the time during this nerve dissection, because you may injure the autonomic nerves. This is the parametrial dissection. Here you can see the uterine artery. And I'm detaching the lymphovascular tissue here, superficial uterine vein, deep uterine vein, and at the deep side of that zone, I will find another vein, which is large. This is it. And deep uterine vein is draining into it, and they are draining towards the internal iliac vein totally. And at the inferior part of this lateral parametria, it's a bit traumatic here. It's a bit traumatic here. You can see many vessels. And here you can see the problem during dissection. Sometimes we cross with the optic camera, and that will obscure our vision. So select your trocars according to your dissection points in the pelvis, according to the surgical areas. Here you can see the deep side of the lateral parametria. There are many veins here. This is the total anatomy of the parietal space again. Lateral parametria, veins. Pelvic splanchnic nerves, hypogastric nerve, ureter, internal iliac artery. And I will continue with the paravesical space. Round ligament, I'm detaching the yellow tissue avascular zone here. And this is the paravesical space, obturator nerve, obliterated umbilical artery, deeply obturator vein. Inferior to the obturator nerve, we may find the obturator vein. Most of the time, the obturator vessels lie inferior to the obturator nerve, and this is the arcus tendinous fascia pelvis, obturator internus muscle, obturator nerve, and suprapubic ramus, coronomortis vessels. They are mostly venous vessels, venous anastomosis, most of the time, approximately 90%, more than 85%, they are venous anastomosis, but sometimes arterial, and they connect with the obturator vessels at the medial side of the nerve. Here you can see. When we detach the obliterated umbilical artery, we will find the medial side of the paravesical space. It's important to reveal the visceral branches of the internal iliac artery, vesical, uterine, and rectal branches. So medial and lateral paravesical spaces. And this is the anatomy of the parectal and paravesical space. This is the parauterine lymphatic tissue. Here you can see it, the supraureteric pathway during sentinel lymph node dissection. Uterine artery, paravesical space, obturator nerve, lateral side of the internal iliac artery, interiliac vision, obturator nerve. Inferior to the internal iliac artery, now I will show you the internal iliac vein. This is the internal iliac vein. And now I will show you psoas major muscle. We are detaching the iliopsoas fascia and medially mobilizing the psoas major muscle. This is the femoral nerve. For type D resections, type D radical hysterectomies, or recurrent cancer cases, it's important. When we detach the external iliac vessels from the psoas major muscle, we develop the medial psoas space. The first superficial nerve here, the obturator nerve, this is covered by the obturator lymph nodes, and inferior to it, we will find the lumbosacral trunk at the lateral side of the internal iliac vein. This is the lumbosacral trunk from L4 and L5, forming the sciatic nerve. Here, this is the lumbosacral trunk, obturator nerve, and lumbosacral trunk. Here you can see this is the area where we find these vessels. So this actually this is the end of the presentation. Maybe we can take some questions, and I will show a video during that time, and we can discuss. The video can turn, and we will discuss. There are many things, but I think that will be enough for. I will show you the ureteric dissection. This is the left side of the pelvis. Here you can see. This is the ureter. bladder side, vesico-uterine tissue, and the uterine artery. It's dissected. We start our dissection from the anterior portion. I will recommend the suprapubic port. It's very, very beneficial, suprapubic port. I use it all the times. When we cut this vesico-uterine tissue here, when we cut it, we will find the distal part of the ureter here. Diminish the tissue from the superlateral part of the ureter. If you diminish this fatty, lymphatic, and vascular tissue from the superlateral part of the ureter, you will easily dissect the ureter. We found that after dissecting the superlateral part of the ureter, we noticed the ureter here. So now I'm dissecting the medial part of the vesico-uterine tissue here. And one tip for this point is that, for this kind of dissection, is that develop the vesicovaginal space deeply. When you develop the vesicovaginal space, it's not important just for bladder dissection. You will change the angle of the ureter like that. Otherwise, the ureter, if you don't dissect the vesicovaginal space deeply, the ureter will go superficially towards the superior part. But if you dissect it deeply, it runs towards the inferior part. And here, after diminishing the superolateral part, we are resecting the supermedial part. This is the paravaginal space, as you understand, from the lateral side of the vagina, between the ureter and the vagina. When we dissect the vesico-uterine tissue, we will easily develop this area, and this area is important for nerve sparing procedures, type C1 radical hysterectomies, and to preserve the bladder nerve branches. When we develop this paravaginal space, this anastomotic area is important. Here, there will be some branches here. You can see connective anastomotic vessels. We dissect them. They are related with the uterine artery or superficial uterine vein, or here at the 12 o'clock position, the vessel, you find that. Put the clips towards the uterine artery level. At the ureteric level, you may not find much more bleeding. This is not important. This is not a bleeding. But at that zone, parauterine zone, uterine artery and vein level, put your clips or energy towards that zone. That area will bleed. So we dissected the ureter from the left side of the vagina. And this is the vesicovaginal ligament here. So this is the ureteric dissection. Step-by-step dissection, reveal the vascular points and identify them. Use energy carefully close to the, if you are close to the ureter, use the energy carefully. There are many videos, but these are the main points. You may find much more during our courses or at my YouTube channel or at our publications, much more. But the main issue during the surgery is know the anatomy very well, improve your anatomical knowledge, watch many surgical videos from the experts, understand how they perform the surgery, and I understand how they reveal the anatomical landmarks. The pelvis is a continuous structure, interconnected structure. All the spaces are interconnected: presacral, pararectal, paravesical, prevesical. So once you identify a space, you can continue your dissection from that zone. Find main landmarks. Ureter is a main landmark. Psoas major muscle, external iliac vessels, pubic bone, promontory. Perform your dissection from the superficial point to the deep point, layer by layer. Predict the next upcoming structure and use your dissection according to it. And once you imagine the upcoming structure, you will use your instrument according to the next structure. Sometimes much more deeply, bluntly, or carefully, or you can use the energy in very very limited, like that. But these are the main points, from the superficial part to the deep part, layer by layer. Main advice is that. Thank you.
Thank you for the presentation, and we have some questions if you want to answer. We have thanks in the question box as well. One question is about corona mortis. Where and when should we look for it and be careful of it?
Yes, I will show it with an figure. Just a second. This is the corona mortis. Here you can see. The right side of the pelvis, external iliac vessels, psoas major muscle, genitofemoral nerve at the anterior side of the psoas major, prevesical space, pubic bone, vagina, paravesical space, pre-anterior to the bladder, para-lateral to the bladder. And this is the obturator nerve at the inferior level of the external iliac vein. And this is superior pubic ramus, superior and lateral part of the pubic bone. Here, over the superior pubic ramus at the lateral side, close to the caudal part of the external iliac vessels at the inguinal ligament level, we may find the corona mortis vessels. Corona mortis vessels are the pubic anastomotic vessels between the external iliac vessels or inferior epigastric vessels and the obturator vessels, or directly arising from them or draining towards them at the obturator canal level here. And here, all the branches which are lying over the superior pubic ramus are called corona mortis vessels. And these vessels are important during pelvic lymphadenectomy if you dissect the lymph nodes at this region. During urogynecologic procedures, if you are performing a birth colpus suspension towards the iliopectineal ligament between the vagina and iliopectineal ligament, or lateral suspension procedures here, these are important. During TVT, it's far away, but if you change the direction of your trocar towards the lateral part, you may injure these vessels. But most of the time, the injury of these vessels are not important. The injury of the major branches. If you injure these branches, they are in connection with the external iliac vessels. And because of the anastomosis, there will be a huge amount of bleeding. During that kind of procedures at that zone, you must be careful about these corona mortis vessels. For example, if you enter the retroperitoneal area from that point of view, it's not problem. But if you enter the retroperitoneal area from the inguinal level, from the inguinal level, you don't see these external iliac anastomotic vessels. You enter that area from the retrograde angle. So you will have a injury at that zone. It's not important in daily practice of gynecology. It's important during inguinofemoral lymph node dissection, the retrograde angle, the retrograde dissection. The inguinofemoral hernia operations like that. But during our gynecology procedures, we notice these vessels during retroperitoneal entry, and it's not problematic for us.
Thank you. And another question is about anatomical landmarks. In cases of massive retroperitoneal bleeding, where a hematoma obscures the normal anatomical planes, which anatomical landmarks can we rely on?
What kind of injury, can you please?
Retroperitoneal bleeding injury, like after delivery or where
First
a
of all,
massive hematoma occurs.
First of all, find the ureter. Find the ureter and use hot water to diminish the thickness of the hematoma. Use hot water, hot towels. Find the ureter. Develop the avascular spaces, firstly parietal or paravesical, which is suitable for you, and identify the internal iliac artery or obliterated umbilical artery. Follow the dissection according to these structures. This is the main issue. Find the ureter. I will show a video if you want for internal
Yes,
iliac
please.
artery ligation. It's always asked. Yes, this is the ligation of the internal iliac artery, and I will show you another video. Things are not easy all the time. There are some videos with bleeding or other things. I will show it. During radical pelvic surgery, it's not easy all the time like that. We noticed many things, and I dissected many cadavers. First of all, this during ligation, during vaginal cuff closure, the ureter was a bit closed, and there was I needed to ligate the uterine artery, suture the uterine artery during laparoscopy. Sometimes, if it's close to that area, I use sutures, not just thermal energy. We had bleeding like that. But at the end of the procedure, everything was safe. I didn't convert to the laparotomy. I will show you where we had bleeding and how it increased. The infraureteric zone is always problematic. Here, this is the right side. You see the ureter here, vaginal level, the uterine artery. I hold it with this grasper, and indeed I can put a suture here, but I thought it was a bit close to the suture, and suturing this uterine artery will change the angle of the ureter. I thought about it. So I tried to make a dissection and lateralize the ureter a bit more. And this superolateral and superomedial parts are not problematic. But if you perform a superomedial dissection close to the vaginal level, there will be some infraureteric veins. Here, I noticed a bleeding. Indeed, it's not much more during that time because of the traction bias. It's increasing, not the arterial bleeding. First of all, because of the traction bias, it's not bleeding too much, but it's bleeding here, you see. I am putting a traction suture here to retract this area. When I take my grasper from that zone and sutured this area, the bleeding increased because of the anastomotic veins. Here you see. It's bleeding from here, you see. First of all, I didn't use the energy. And I hold the medial side of the vagina. Look at here. It's coming from the medial side, mainly. I hold the medial side. Now the infraureteric portion, this area is bleeding. I am press the area where it bleeds. So you may decrease the amount of bleeding. Never use energy without clarification the point of ureter. Here, this is the area of bleeding, the anastomotic vessels. I'm pressing that zone, not using energy, just holding the area with the energy device. Here, just putting pressure. and thinking, giving information to the anesthesiology. If you need help, call for help. But first of all, press that zone and clarify the area. Never use energy without identification of the anatomical landmarks. This infraretheric zone I changed the direction of the camera point of view. Here you see the area. I put a pressure. This is the traction bias, you see? Because of the angle of traction, the bleeding diminished. The ureter is lying here. Yes, this is the area of bleeding. Now, I pulled it medially towards the pelvic brim level, so I find the bleeding area. You see? A few seconds ago, no bleeding. Now I hold the bleeding area, medial to the ureter. You see? This is the energy device, but I'm not using energy. I hold this bleeding with a grasper. You can suture it or you can use clips, other things. So this is real life. You may, even if you are very experienced or other things, you may have an unexpected bleeding. You see, I'm pressing towards the bladder level to decrease the amount of bleeding and use suction. During a bleeding time, if you don't have bleeding, be quick. Be quick, hold it, and use clips or other suture or something else, secure the ureter, use energy, or after securing the ureter. But any tiny movement, any slow movement, even any slow movement, tiny movement will cause bleeding. Because these vessels are very anastomotic. So always use the traction bias. When I use a traction like that, it's not bleeding. Do you see? And give information to the surgical nurse also. Prepare a table for laparotomy if you need that. I'm holding this area like that, no bleeding. So now no problem. Prepare the surgical field for you, for your management. If you need to wait for some instruments or help or other things or something like that, press and wait. If no bleeding, no problem. Here, when I identified the area of the bleeding, this is the area of the bleeding. Now I'm going to lateralize the ureter. Here. When I put this area towards the medial side, it has a bleeding, you see? And even during bleeding, if it bleeds a bit more, you will think that you are in danger, and you will lose your objective evaluation capacity. So always be calm in danger times. And my suggestion is that if you have a bleeding from just a single zone, more than 300 milliliters from just a single zone during laparoscopy, be careful and think about conversion to laparotomy from the bleeding is just from a single zone. For example, just from here, more than 300 milliliters, think about conversion. It depends on your experience. If you are experienced, it will be 500 milliliters for you, or more than 500 milliliters. But if you are not very experienced, 200 or 300 milliliters from a single zone will be very dangerous for you. If you cannot stop the bleeding until 200 milliliters, it's a bit difficult. It will be a bit difficult for you to stop it after that. Or it depends on your experience, but think about the issues after 200 or 300 milliliters and the accompanying factors. Here you see that I'm using 3 trocars. It's bleeding. It's very difficult. Sometimes because of the suction, you may use your abdominal pressure. And here you see the ureter is at the lateral side. This is the bleeding zones. This is the main area. Sometimes the deep uterine vein has anastomotic branches with the vagina here at the inferior ureteric zone. So the inferior ureteric zone is always problem here. This is the anastomotic branch. And this is the line of the ureter, you see? And now I'm using clips. I can suture that zone, but I used sutures this time. I discussed this video with my urologist colleague, and I asked about these clips. It's not problematic if they are not very close to the ureter. They are not very close. They are lying at the lateral zone. Here you can see the line of the ureter. It's secure. And I didn't use energy. Here you see. I'm checking the ureter. It's at the lateral margin, you see. I used another clips here and ligating the medial side, not close to the ureter, and I take my trocar, a grasper, so no bleeding. I'm going to release this suture, no bleeding. So we managed it. but it will be problematic. And the patient didn't have any complications postoperatively. During pelvic surgery, everything will be problematic. And if you are at the inferior zone, so be careful for that. Even if you are at the superior zone, I showed the anastomotic vessels superior to the ureter to you from the cadaveric dissections. So the biggest advice is that layer by layer dissection for complex cases. This is a laparoscopic hysterectomy, and I'm going to show again how the bleeding happened. This a complication, just one movement. Just single blunt movement. Just a second. Here, look at me. Indeed, this area is secure. Even if I'm going to suture that zone, I have a space with the ureter that will not cause problem. But during surgery, sometimes you will lose your objective evaluation and think that there will be a complication. And I released the superlateral angle, and this area is also now good. But just one movement will cause you everything. Just a second. It's secure. Here, that zone. Look at that. A small bleeding will be much more. Here, it starts bleeding. So always be careful. Always, always, always be alert during surgery. And later think about your surgeries, your complications. Watch your videos and think about the surgeries, what you did. How can I handle that situation? And how can it be better? Understand them, accept them, and try to make them better. Afterwards, you can be a good surgeon.
Thank you, Professor. There is one more question if you have time to answer.
Yes, exactly.
Is there a higher risk introducing the trocar to the space of retius extraperitoneal instead of intraperitoneal, as in the two approaches to the laparoscopic colpos suspension?
To prevesical space?
Introducing the trocar to the space of retius extraperitoneal instead of intraperitoneal, as in the two approaches to the laparoscopic colpos suspension. You can also see the question.
I didn't understand indeed the question, but
If Dr.
when
Murat
you
is online, he can maybe ask one more time or write to make it more clear.
colpos suspension during prevesical entry, we
Yes,
have no problems. When you enter the optic trocar, you see all the areas, and if you empty the bladder, you will have no complication. It's not easy. Cut the peritoneum and dissect the posterior part of the pubic bone. For optic trocar entry, no problem. For extraperitoneal insertion of optic trocar, we use open entry also. I always, all the time, even no risk patients, I use the open entry. And just for the lateral trocars, I will show you this figure. Just a second. Just a second. from our chapter here. For example, during lateral trocar entry, you put the oblique trocar from here, and this is the inferior epigastric vessels. You see that. These are the superficial vessels. They are not important. They arise from the femoral artery, superficial epigastric artery. But these inferior epigastric vessels, they lie lateral to the obliterated umbilical artery. This is the posterior side of the anterior abdominal wall. Inferior epigastric vessels, they lie lateral to the obliterated umbilical artery, and your trocar must be lateral to them. Lateral to them. Your secondary trocars must be lateral to them. So if you don't injure them, there will be no problem. If you injure them, if we have an injury of the inferior epigastric vessels, I suture that point. No problem. I suture that area. But this is the area, for example, for the supravesical trocar, suprapubic trocar entry. Again. And just be careful about the inferior epigastric artery.
Thank you.
If there are questions or other things.
I think it was the last question
Yes.
for now. Thank you for the presentation and thank you for time. And can we maybe take a photo before we finish the
Yes,
session?
exactly.
Okay. So I will count on 3. I will take the photo. 1, 2, 3. Another one. 1, 2, 3. Okay. Thank you very much.
Thank you. It's an honor for me, and I really like that. It's a joy. I really enjoyed from this presentation and your friendship, dear colleagues.
Thank you very much.
Thank you for everything.
Thank you very much.
Bye.
Bye-bye.